Hey everyone, Allie Hensley here. I'm going to be doing my patient care presentation on symptomatic AFib, specifically looking at AFib ablations and the procedure and how we care for them after. So my patient that I was taking care of, John Doe, age 50 to 60-year-old male, he had a cryoablation done with a TEE. He was having symptomatic AFib. So he was having heart palpitations and dyspnea on exertion. So he was admitted from home. He had So we all know what AFib is, but here's just a little bit of a refresher. So on the top picture there's a normal cardiac rhythm. So there's a normal P wave, there's a normal QRS, and then there's a T wave. Below that picture, there's the atrial fibrillation cardiac strip. You can see that there's no distinct P wave. The QRSs are there, but there's no normal rhythm. So it's an irregular heartbeat where the atrias don't contract regularly. They just kind of fibrillate. So AFib is the most common cardiac arrhythmia. It's found most of the time in ages 65 to 85. It's seen in 1.5 to 2% of the general population. There's more than 2 million people in the US that have AFib. I didn't realize how prevalent it actually was until I actually looked at it. So basically the complications from AFib is, since you're not having a normal cardiac rhythm, the blood in the heart just kind of can stay there and sit there. So you're increased risk for stroke, and then you're at risk for developing heart failure too. So why AFib is such a big deal, it's accounted for 35,000 million hospitalizations and 5 million office visits yearly in the US, which I think is crazy. One of the treatment options for AFib is called an ablation. This one's normally one of the last treatment options they try. The first treatment option they try is pharmacological interventions like anticoagulation and antiarrhythmics. I said previously my patient I was taking care of who was on Xarelto and amiodarone, but he was still having those symptoms of AFib, so they decided to do an ablation. So before you go for your ablation, you'll have extensive imaging done. He had a TEE done or a transesophageal echocardiogram to determine where the AFib is actually coming from. Most of the time it's by the pulmonary veins. It's kind of where the cardiac tissue kind of takes over and makes that irregular rhythm happen. So they can do extensive imaging to see exactly where they want to ablate or where it's coming from. So there are two different types of ablations. There's a radiofrequency ablation that uses heat to ablate the surrounding tissue. And then there's also a cryoablation, which my patient had. He had, which uses cool or freezing to ablate or paralyze the surrounding tissue that causes the AFib. This is hopefully to make it go away. Normally, they go through the groins, the right and left groin. They'll take catheters and thread them up to the heart through the inferior vena cava. And since they have all that imaging done, they can look exactly where to ablate. So for my plan of care for an ablation patient, we are monitoring them very closely and making sure everything stays stable. So we put them on a telemonitor right away so the CMR can monitor them while they're there. We're looking at their sites very frequently, their groin sites. We look for bleeding and hematomas. I'll kind of go over that in my algorithm a little bit. They get an EKG done right when they get to the floor. So with those site checks, we're also doing vitals every check. We're doing a peripheral vascular check every check, and we're doing a site assessment. So making sure all that information gets put into consideration. So my goals for these types of patients is that they don't complain of any pain. So no chest pain or no shortness of breath. If those would occur, I would let the doctor know right away. And then also just keeping precaution of their like bleeding or hematomas that would occur. So my interventions that I would do for these patients is educating them on staying bed rest. Their bed rest for 6 hours after their procedure. So that also includes of keeping the head of the bed lower than 30 degrees. I'd ask them about pain every time I was in there. So you're monitoring their blood pressure and their sites very frequently. Most of the time, these patients get to go home in the morning after their procedure. So just making sure that they have the good education that they need so they can go home. They would follow up with their doctor within a month. So I'm going to go through my algorithm real quick. So an ablation patient will come up from EP lab. We'll have to move them over to the bed. They'll have to stay bed rest for 6 hours. So we'll need a bunch of people in that room to help them move them over. We'll place them on a telemonitor for their stay. We'll look at the sites, and when the next site check is due, they pull sheath downstairs and start 15-minute vitals right then. So they need frequent site checks and checks done. We'll need to get an EKG right when they come up from the floor. So checks are done. There's 4 15-minute checks, there's 2 30-minute checks, and then there's 4 1-hour checks. And then after that 4th 1 hour, then they're Q4 checks. So with checks, we're checking vitals, we're checking their site, and then we're also checking their peripheral vascular. So for vitals, if the vitals stay stable, we just continue to monitor them throughout those checks. If there was a drop in blood pressure, you would do the same thing you would do for any drop in blood pressure. You would start fluids, you'd put them in Trendelenburg, and then you'd call the doctor. For site checks, we're looking for hematomas or bleeding. So if there's none of that, we'll just continue to monitor them for their next check. If that would occur, we would need to apply pressure right away and call the doctor. So hematomas normally dissolve right back into the skin, but just applying that pressure dressing right away is very important. So with peripheral vascular checks, if we're looking for good pulses, we're looking for are they warm, do they have good cap refill, any pain too. So if there's no complications that would occur, we would just continue to monitor them for the next for their next check. If there would be a change in baseline, so if they would lose pulses or if they would suddenly become really cold in that extremity, we'll call the doctor right away because that's very, very important. So after that 4th check, or that 4th 1 hour check, we help the patient get up and walk around. So they've been laying flat in that bed for a while, so we'll have them sit up and very slowly so they don't get dizzy or anything. We'll have them walk around the room, we'll have them sit back down, and we're going to check their sites right away. So if there was no hematoma that formed, or if there was no bleeding, we can remove their urinary catheter that they have. We're going to check their sites again. If there was no complications, you just continue to monitor. For any hematoma formation or bleeding that would occur, you would apply pressure and call the doctor right away. So in the morning, they would get discharged, most likely. They'll need a morning EKG done. And if there was no complications during the night, we would educate them, and then we would discharge them. So educating them on no exercising for a week, no lifting over 10 pounds until you see your doctor, no tub baths, so they can shower, but since they do have those open, or they're not healed groin sites, we don't want to introduce any bacteria, so no tub baths. And they did just have a procedure done, so no strenuous activity. So they have to keep their legs kind of straight, no bending, no lifting or anything. So, but if there was complications that would occur that would deteriorate them from leaving, we would let the doctor know right away and then just continue to care for them. So to summarize my presentation, AFib can be symptomatic or it can be non-symptomatic. So ablations are done for symptomatic AFib. It's one of the last treatments for AFib. With a ablation patient, you are constantly monitoring for hematomas or bleeding. If those would occur, you apply pressure right away and you call the doctor. Those are pretty important to monitor for. Most of the time these patients get discharged the next day, so it's educating them on how to care for this while they go home too, and then making sure they follow up within a month. These are the references I used to find my information for my project.